Hi, my name is Hannah. I am an APRN student, and I am presenting familial hypercholesterolemia. The incidence of familial hypercholesterolemia, it's a relatively actually common condition. It can either be a single gene mutation or multiple single nucleotide polymorphisms. There's two types, heterozygous, well actually three, heterozygous, homozygous, and compound heterozygous. Heterozygous familial hypercholesterolemia is about 1 in 250 people. However, it's often underdiagnosed. It ultimately leads to elevated LDL-C levels and increases the risk of premature cardiovascular disease. It's most common in French Canadians, Ashkenazi Jews, Lebanese, and South African populations, in which the incidence is about 1 out of 100 people. In these patients, the untreated LDL-C levels range from about 155 to 500. Compound heterozygotes, the inheritance of different mutation from each parent. So each parent gives the child a mutated gene, but the mutation is different. Homozygous FH is very rare. There wasn't information regarding the exact incidence that I could find. However, both compound heterozygotes and homozygotes have LDL-C levels of greater than 500 untreated. The inheritance is it's an autosomal dominant disorder. There are multiple mutations that all can result in FH. The most common is LDLR, or the LDL receptor. It accounts for approximately 85 to 90% of patients. There are over 900 different mutations of this gene, all of which result in the decreased capacity to clear LDL from the circulation. Another one is ApoB, which is impaired LDLR binding. The mutation is actually on the binding site. This is approximately 5 to 10% of incidence. PCSK9 mutation is very rare. It results in an increased degradation of the LDL receptors. The LDL adapter protein is another rare, this one is actually an autosomal recessive trait, results in decreased production of the protein required for the clathrin-mediated internalization of the LDL receptor. The pathophysiology behind FH, ultimately there's a decreased function of the LDL receptors, which can be due to a variety of things, either decreased synthesis of the receptors, poor transportation of the LDLR out of the endoplasmic reticulum. The LDLR doesn't bind LDL on the cell surface, or the LDLR doesn't properly cluster in the clathrin-coated pits for the receptor endocytosis. The end result of all of these is a decreased endocytosis of LDL, thereby increasing circulating levels of LDL, and high LDL levels are linked to increased atherosclerotic plaque development. The age of onset differs slightly between heterozygous FH and homozygous FH. The heterozygous is usually in adulthood at around 40 and over. The homozygous can be seen around 10 years old. Diagnosis is made based on lipid levels, family history, physical findings, and genetic testing results. The physical exam findings include xanthomas, or cholesterol deposits, which can occur around eyelids, tendons of the elbows, hands, knees, and feet. Also can be evidence of coronary artery disease such as angina, MI, or other atherosclerotic disease such as strokes, or arcus coronae. One, should you consider testing someone for FH during routine screenings if they have evidence of premature cardiovascular disease, if they have fasting LDLs of greater than 190, untreated LDLs greater than 250 in adults over 30, greater than 220 in adults 20 to 29, or greater than 190 in patients under 20. If they have evidence of corneal arcus in under 40 years old, if they have tendon xanthomas, family history of premature cardiovascular disease, or family history of hypercholesterolemia. The diagnostic tools, there's three major ones that I found for which providers can use to diagnose a patient with FH. The U.S. Make Early Diagnosis Prevent Early Deaths program diagnostic criteria uses total LDL measurements and family history, which is really not useful in children. The Dutch Lipid Clinic Network diagnostic criteria is a point system using LDL levels, exam findings, family and personal history of coronary artery disease in the presence of a genetic mutation. The Simon Broom Register diagnostic criteria uses LDL levels, family history, presence or absence of tendon xanthomas, as well as the presence of genetic mutation. Screening for FH should be done in first and second degree relatives of someone who was diagnosed. Serum cholesterol should also be checked routinely during primary care evaluations starting at 20 and also between 9 and 11 years old. There should also, for children who have a strong family history of early cardiovascular disease in the family or have had elevated cholesterol levels, should actually be started at 2 if there's a high likelihood of homozygous FH. There are 3 types of genetic testing that are most commonly used for FH. They are sequence analysis of select exons, the deletion or duplication analysis, and sequence analysis of the entire coding region. Prognosis of FH is dependent on heterozygosity versus homozygosity. Heterozygous FH, 5% of patients will have an MI before they hit 60, and 20% of patients who have an MI under 45 also have FH. Homozygous FH is much more severe, and cardiac events can occur as early as the first or second decade of life if untreated. Non-pharmacological treatments include lifestyle changes such as diet modifications, moderate alcohol consumption, regular physical activity 30 minutes a day, 5 days a week, maintaining a normal BMI, and avoidance and cessation of smoking. Pharmacological treatments include anti-lipid agents such as statins, PCSK9 inhibitors, bile acid sequestrants, fenofibrates, and ezetimibe. Management of comorbid conditions such as diabetes and hypertension, which are contributory to cardiovascular disease. And it's recommended to have either 81 or 325 milligrams of aspirin, depending on the patient's other comorbid conditions and risks. Lipid-lowering therapies include high-intensity statin, bile acid sequestrants, and the use of PCSK9 inhibitors. Statins are the high-intensity statins include atorvastatin 40 to 80 or rosuvastatin 20 to 40. These are HMG-CoA reductase inhibitors. They increase the number of the LDLR or the LDL receptors on the liver, which stimulates the breakdown of LDL. They also have the added benefit of reducing inflammation at the site of coronary plaque. Ezetimibe, or Azetia is easier to say, actually blocks the absorption of cholesterol along the brush border in the small intestine, reducing circulating LDL levels. PCSK9 inhibitors are newer on the market. They're an injectable about once or 2 times a month. They're a monoclonal antibody. They block the protein PCSK9, and the role of PCSK9 is to deactivate the LDLR receptors. So by inhibiting the activity of the PCSK9 proteins, they enable there to be more LDLR or LDL receptors on the liver, which allows for more breakdown of LDL and reduces circulating LDL-C. Social, ethical, and financial considerations of FH. Cost can be very substantial, especially with the newer monoclonal antibodies. The PCSK9 inhibitors can be up to $14,000 a year, which would be cost prohibitive for some patients. Ethical considerations, it's really important to have early screening and primary care management for these patients, and trying to close some of the health disparities that are present in our communities to allow for appropriate screening of patients. Social implications. There's many necessary lifestyle modifications that are necessary in order to help maintain normal or lower LDL levels, which can hinder a person's ability to feel able to participate in social situations. So my resources, and thank you, I hope you guys learned something about familial hypercholesterolemia today.